Welcome back, everyone. Let's just jump right in. Look, if you're a medical coder, I know firsthand that just looking at the CPT manual sections for pediatric critical care, intensive care, and cognitive assessments, well, it can cause an instant spike in your blood pressure. The rules are strict, the time blocks are super specific, and the bundled services can totally trip you up. But hey, don't worry. In this explainer, we're going to completely demystify these notoriously tricky codes. I've designed a foolproof, visual cheat sheet approach that's going to transform these complex guidelines into clear, manageable rules that you can confidently apply every single day. So here's our agenda for today. We'll start with pediatric critical care transport, then we'll move into inpatient neonatal and pediatric care. After that, we'll tackle weight-based intensive care services, and finally, we'll wrap up by decoding cognitive assessment plans.
All right, Section 1, Pediatric Critical Care Transport, focusing on time and presence variables.
Now, for these transport codes, literally everything anchors on exactly where the physician is and exactly how many minutes they're dedicating to the patient. So we're talking specifically about the interfacility transport of a critically ill or critically injured pediatric patient who is 24 months of age or younger. Notice the clear line drawn between two very different types of physician work here. On the left side, we have face-to-face, hands-on transport care. This means the physician is physically right there in the ambulance or helicopter directly attending to that young patient. On the right side, though, we have the control physician. This is non-face-to-face supervision. The control physician is stationed back at a facility communicating two-way with the specialized transport team that's actually moving the patient. So they're providing treatment advice and directing care from afar, but they are not physically riding along. And remember, you can never, ever report these two sets of codes together for the same patient by the same physician.
Go ahead and take a mental screenshot of this slide right now, because these exact minute thresholds are what dictate your coding. Okay, for the hands-on, face-to-face transport, your base code is 99466, and that covers the first 30 to 74 minutes of direct contact. If the transport goes longer, you use the add-on code 99467 for each additional 30 minutes. Now, for the control physician providing non-face-to-face supervision, the base code is 99485. The really crucial point here is that this code only kicks in if the supervision lasts between 16 and 30 minutes. If they spend 15 minutes or less, it's just not reported. If they spend more than 30 minutes, you report the add-on code 99486 for each additional 30-minute block.
Okay, moving right along to Section 2. Inpatient, neonatal, and pediatric care, and age-based global codes. So we're shifting gears from time-based transport codes to age-based global codes. In the inpatient setting, our critical variable completely changes. We're no longer counting minutes. Instead, we're looking at the patient's exact age to assign a global per-day code. This table is a great visual cheat sheet for the 3 strict age brackets you've got to memorize. First up, we have the neonate, which is defined as 28 days of age or younger. Their initial day of critical care is coded as 99468, and any subsequent days are 99469. Second, the infant or young child from 29 days through 24 months of age. Their initial critical care day is 99471, and subsequent days are 99472. And third, the older pediatric patient, covering 2 years through 5 years of age. For them, you'll report 99475 for the initial day and 99476 for subsequent days. Remember, these are per-day global codes. That means they're reported only once per calendar day, per patient by a single individual. And once a patient hits 6 years of age, they age right out of this table, and you move over to the standard time-based adult critical care codes, which are 99291 and 99292.
Now, please pay close attention to this because it is a massive gotcha moment in medical coding. When you report those global per-day neonatal or pediatric critical care codes we just looked at, they are heavily bundled. You must never, ever unbundle and bill separately for standard critical care procedures performed on that same day. This includes vascular access procedures like umbilical catheters, airway and ventilation management like endotracheal intubation or CPAP, lumbar punctures, and the monitoring or interpretation of blood gases or oxygen saturation. These are all considered inherently part of the critical care work for that day. If you code them separately, you are looking at an immediate denial.
Let's jump into Section 3, weight-based intensive care services.
All right, we're changing our anchoring variable once again. We've done time, we've done age, and now we are anchoring on present body weight. It's absolutely vital to understand the clinical distinction here. Codes 99477 through 99480 are for infants and neonates who are not critically ill. They just don't meet the definition of critical care. However, they still require a very high level of intensive observation, frequent interventions, and constant monitoring by the healthcare team, under the direct supervision of a physician. Think of a baby who needs continuous cardiac and respiratory monitoring or really frequent vital sign checks, but they aren't in imminent danger of multiple organ failure. For the very first day this intensive care is provided to a neonate 28 days or younger, you use the initial care code, 99477.
Let's see how this builds for the days that follow. For subsequent continuing intensive care, your code selection is based entirely on the infant's present body weight, and I mean what they weigh on that specific day, not their birth weight. If their present body weight is very low, meaning less than 1,500 grams, you report 99478. If they have a low body weight, between 1,500 and 2,500 grams, you use 99479. And for a normal body rate, defined here as 2,501 to 5,000 grams, the code is 99480. Make sure you don't mix up these weight criteria with the age criteria we covered in the previous section. Oh, and if the recovering neonate exceeds 5,000 grams, you transition out of these codes entirely and look at standard subsequent hospital care codes. Finally, Section 4, Decoding Cognitive Assessment Plans.
We are completely leaving the pediatric inpatient setting now and moving into the outpatient world, where documentation is absolute king. Code 99483 is a highly unique EMM code. It represents a comprehensive clinical evaluation for a patient who's exhibiting signs of cognitive impairment. The goal here is to establish or confirm the diagnosis, figure out the etiology, and determine the severity of the condition. Because this is such a massive, deep dive into the patient's medical and psychosocial factors, this code typically consumes about 60 minutes of the provider's total time on the date of the encounter.
Notice the mandatory elements required here. This is literally an all-or-nothing code. To report 99483, your documentation must contain every single one of these mandatory elements. You need a cognition-focused exam and history. You need a functional assessment of their daily living activities. You absolutely must use a standardized tool for dementia staging like the FAST or CDR scales. You've got to do a medication reconciliation, specifically looking for high-risk meds. You must evaluate their safety, including their ability to drive or live at home. You have to identify and assess their caregivers. You must address advanced care planning. And finally, you have to create a written care plan and actually share it with the patient or caregiver. If even one of these exhaustively strict documentation elements is missing, or even just deemed unnecessary for the patient, you simply cannot bill 99483. You'd have to default to a standard EM code instead. I want you to burn this number into your memory right now, 180. Because code 99483 is such an exhaustive, massive evaluation, CPT guidelines place a very strict frequency limit on it. A single physician or other qualified healthcare professional cannot report code 99483 more than once every 180 days for a particular patient.
Mastering these specialized EM codes takes practice, but by breaking them down by their core variables, whether that's time, age, present body weight, or strict documentation checklists, you can tackle any chart that comes your way. Use this explainer as your visual roadmap, and you'll be coding these complex scenarios with total confidence. But as healthcare shifts further toward AI and automated billing, will mastering these nuanced manual codes become a lost art, or will it be your ultimate competitive advantage in the industry? Think about it. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.